we are Pro-Cervical Auscultation. According to Leslie in 2007, cervical auscultation, or CA, is the use of a listening device to assess swallowing and respiratory sounds. Judgments are then made on the degree of impairments of the sounds. Listeners interpret the sounds and suggest what might be happening with the swallow or causing impairment. CA is non-invasive, inexpensive, good for all ages, and so fast it only makes sense to add it to the other aspects of a bedside eval.
While the most common listening device is a stethoscope, according to Cicero and Murdoch 2002, the best acoustic detector unit for picking up swallowing sounds was a microphone as opposed to an accelerometer. Since it had a higher signal-to-noise ratio, it was less expensive and more readily available. In addition, cervical auscultation with a microphone is easily done in a clinical setting and has the added ability to record the swallowing sounds. This would allow the clinician to return to the recording again and potentially review and analyze the sound with other clinicians. It can also be used to guide referral to instrumental evaluations and form tentative hypotheses about the pathophysiology.
According to Bowles in 2013, scientific evidence supports that 3 points on the neck are credible for cervical auscultation. These points show a good signal-to-sound relationship and little variation of the swallowing signal. These areas include the midline of the cricoid cartilage, immediately inferior to the cricoid cartilage, and the lateral border of the trachea inferior to the cricoid cartilage. Positioning near the cricoid cartilage is favorable because it presents as a resonator itself, which in addition to being a point of reference, will improve acoustic sound.
You can be confident in the ability to hear deglutition apnea, which is the period where breathing stops during the swallow, and whether or not there are multiple swallows during the trial, which has been shown to be indicative of dysphagia via Bohr 2007. Numerous professional clinicians who use CA claim that the following swallowing events can be heard: the sound of bolus transferring into hypopharynx, the sound of bolus passing through an open UES, and the sound of glottal or laryngeal release during expiration post-swallow.
Currently, a bedside evaluation includes a case history, oral motor assessment, and observation of wet vocal quality. For each of these components of the bedside, there is significant variability in their sensitivity and specificity to dysphagia in the literature, analyzed in an article by Bergstrom 2014. Sensitivity is the ability to correctly identify people with the condition. Specificity is the ability to correctly identify people without the condition. For example, Rosenbeck reported wet vocal quality having 50% sensitivity, meaning dysphagia was only accurately identified half the time in patients that actually had dysphagia. However, articles by Bohr and Takahashi reported CA having sensitivity up to 94%. Meanwhile, specificity for oral motor assessments ranged from 18 to 84%, while CA reported a smaller specificity range of 70 to 93%, illustrating that adding CA into the bedside will only improve sensitivity and specificity.
Intra-rater reliability for CA is quite variable via Stroud 2002. However, some individual therapists achieve such high reliability that they must be using successful internal criteria that further qualitative research should be able to identify, in much the same way respiratory auscultation was standardized. Additionally, in Bergstrom 2014, the inter-rater reliability for severity ratings of dysphagia with CA was found to be higher than inter-rater reliability severity ratings of both pharyngeal residue and PAS scale ratings, using video fluoroscopy and FEES, via Kelly 2006 and 2007. Therefore, CA shows the future capability of being reliably trained in clinicians and has additionally been shown to demonstrate a higher agreement between clinicians than FEES and video fluoroscopy when it comes to rating severity of dysphagia.
In conclusion, CA is a sufficient and useful addition to the bedside evaluation that can only benefit and not damage its execution.